the delegates to leave for the same. Thank you.
On to the first session of today, named Diabetes Challenges. The first segment will be chaired by Professor Dr. A. Bavatarni, Senior Consultant Diabetologist, Erode, and Professor P. Pananaman, MD, General Medicine, Professor and Head of Department, General Medicine, Kilpauk Medical College. We would like the chairpersons to take the stage, please. Now, Dr. S. Appandraj, MD, General Medicine, Professor and Head of Department, General Medicine, MAPIMS, Melmarvatur, Executive Council Member of TN API, Founder and Honorable General Secretary, API Chengalpet, Organizing and Scientific Committee Chairman, MID Tapicon 2022, Resource Person for RBCW and CISP, and Member of MEU. Sir has presented more than 15 international papers. He will be speaking on the topic Glycemic Variability and the role of continuous glucose monitoring in GDM. Over to you, sir.
Good morning, everyone. Very happy to be in front of august audience. Thanks, Dr. Arulraj sir, Dr. Parandaman sir, Dr. Pichmani sir, Dr. Hariharan for giving me the opportunity. The topic I am going to talk is role of glycemic variability and continuous glucose monitoring in gestational diabetes mellitus. By anything, we will go for introduction. Gestational diabetes is glucose intolerance that occurs in the pregnant women. It is mainly because of the insulin resistance that caused because of the pregnancy hormones, which is not adequately compensated by means of pancreatic beta cells. In India itself, we have more than 5 million women annually suffering from gestational diabetes. And this prevalence also, many things have been underreported, and the prevalence rates ranges from 4% to 18%. And this GDM increases the obstetrical complications and adverse fetal outcomes. They include preeclampsia, cesarean delivery, stillbirth, and macrosomia. And continuous glucose monitoring is a method in which the subcutaneous sensor is used to collect the glycemic results. The main benefit of them is after the insertion, the actual glycemia has been measured constantly, by a minimally invasive procedure without having any additional invasive. An important advantage is evaluation of the time the patient spends in the normoglycemia, because nowadays the concept is time in range. That is the patient who is maintaining the glucose in the range, and it is defined as the percentage of time of glycemia in the reference range. Reference range is not the same for ordinary diabetic patient, older individuals, and pregnancy, but we will be seeing that. So it is believed that time in range is more accurate outcome to assess the patient's compliance. And we all know there is advantages of HbA1c. It is very easy to measure. Nowadays it is very cheap and predictive of vascular complications, because higher the HbA1c is going to be a problem, and it helps in taking the treatment decision. So when to start insulin, when to start OHS, like that. But it has its own limitations. It is inability to measure the acute glucose fluctuations. Glycemic variabilities are not measured by it, and unreliable in many conditions like renal failure, pregnancy, hemoglobinopathies. And there comes the glucose monitoring devices. They provide information about the glucose values, and they are efficient and safe by controlling the glucose, by detecting the fluctuations. These devices are crucial in patients who are having high risk for hypoglycemia and hyperglycemia. Diabetic monitoring systems has been currently evolved, and we have a lot of evaluation from first generation reflex meters to second generation glucose monitoring system. We have glucometer to third generation continuous glucose monitoring, and we have many non-invasive fourth generation also. And these are the various diabetes monitoring technologies: conventional method, self-monitoring of blood glucose, continuous glucose monitoring, non-invasive glucose monitoring, closed loop system, and we have insulin pump, and we have later mobile technology, and we have professional CGMS, personal CGMS, and real-time CGMS. and glycemic variability. It plays an integral component of glucose hemostasis. It is emerging as an important measure to consider when assessing the glycemic control. It represents the presence of excessive glycemic excursions within a day, and GV is more meaningful to measure the glycemic control even than the HbA1c, and it takes into account the intraglycemic excursions, including the episodes of hyperglycemia and hypoglycemia. So it is a predictor for the future risk factors. And we have long term and short term. Predominantly, we have two types of glycemic variability. One can be measured by means of self-monitoring of blood glucose, HbA1c, which is considered as long-term glycemic variability. But short-term glycemic variability is the one that changes every day, every hour, every minute. So, and its clinical significance is this glycemic variability has a role in accelerating the complications of type 2 DM. It is an independent predictor for the chronic diabetic complications besides HbA1c. It is higher in people with the diabetes and the impact glucose regulation, and it differs in patients with the type 1 DM, type 2 DM, and those who are on dietary and oral hypoglycemic agents. So the time in range, an evolving metric to measure the GV. So time in range should be as much as increased. Every percentage increase in the time in range will be helpful in reducing the complications. Time below range, that is hypoglycemic episodes, it is considered as very low is less than 54, and 54 to 69 is considered as low, level 1 hypoglycemia and level 2. Similarly, very high is greater than 250, and very high is considered as level 1 hyperglycemia, that is 180 to 250. And this is the way in which measures. It not only takes the HbA1c or sugar value at some point, it takes continuous measuring, and it includes hypoglycemic episodes, hyperglycemic episodes, and taken into consideration. And target in range, targets for different diabetic population. So when you expect HbA1c to be 7, at least 70% of the time, your glycemic control should be within the range, that is between 70 to 180 in type 1 and type 2 diabetes patients. In elderly age, we can keep greater than 50, not 70, in order to avoid hypoglycemia. In pregnancy, especially gestational and type 2 diabetes, definitely it should be kept at more level, at least 80%. And every 10% decrease in time in range increases the retinopathy by 64%, increases the nephropathy by 40%, and increases the neuropathy by 25%. So carbohydrate intolerance of various degrees have been present during the pregnancy. This is irrespective of the insulin control. It gives the perinatal outcomes, both obstetric as well as the neonatal, as well as the risk of future DM for the kid, and occult type 2 diabetes mellitus. And pregnancy is a critical time for control. If the HbA1c is less than 8.5, malformations is 3.4. If it is greater than 8.5, the malformation is 22.4%, a steep increase in the malformation, and that's why a strict control is needed for pregnancy. So fasting blood glucose less than 90, 1 hour PP less than 140, 2 hour PP less than 120, and HbA1c between 6 and 6.5 is the target for pregnancy. We'll see two case studies. 22-year female, second gravida, 24 weeks pregnant, no family history, no PCOS, and no history of GDM, normal weight. Patient has fasting of 104, target is 90, 1 hour postprandial is 186, and 2 hour postprandial is 184. And diet has been done for this patient. In spite of that, we can see the postprandial alone, fasting has got control, but postprandial, both dinner and breakfast, lunch, it has been increased, especially in the breakfast and diet. So what we have to advise for this patient, short acting or ultra short acting insulin. 4 units has been started and patient got the glycemic control. And second case is 24 years female, lean and 46 days pregnant. Fasting is 106 and postprandial is 262 and HbA1c is 8.7. Okay, so it is a pre-gestational diabetes. And the patient is already on injection Humalog 10-10-0 and Humalog mix 25. And two strategy has been formed, in which the first strategy, we can see the patient is undergoing hypoglycemia in the postprandial of the lunch, and dinner postprandial is higher. So we have to reduce the dose of pre-lunch and increase the dose of postprandial dinner. So change 1 has been done, Humalog 10-6-0 and Humalog mix 25 has been increased to 14. And continuous glucose monitoring is done, and this is done before the change, and after the change you can see the sugar is under control. You can see the 98% achievement has been done. With the change 2 also, we can see the control is more than 89% on 29th August. And need for CGM in pregnancy. Pregnancy, definitely the goal is safely to increase the time in range as quickly as possible. And we have lot of studies to say why patients should be in time and range. And a statistically significant relationship was observed between time in hyperglycemia after lunch and macrosomia. And it has been proven beyond doubt the postprandial hyperglycemia causes macrosomia. And pharmacological treatment has been required in all these patients. And there are studies from Sweden and also the concept trial which reported 50% time in range in the first trimester. When it is increased to 60 and other, it reduces the complications. And we have Law et al. Analyzed the data of 2 yearly CGM trials, and they describe the associations of CGM measures and the risk of large for gestational age infants. Taken together of these three, even increasing the time in range by 5 to 7% is associated with better outcome, maternal as well as fetal outcome. But there are some studies which gives inconclusive, though they say continuous glucose monitoring is better in finding the episodes of hypoglycemia, hyperglycemia. But when it comes for the outcome, maternal and fetal outcome, this glycemic variability doesn't play much role. Law et al. And Payankat et al. They didn't show much significant, statistically significant values. But there are again other studies which show greater blood glucose fluctuations are more likely to cause adverse maternal and the infant outcomes. And it is considered as an independent risk factor for large for gestational age, short for gestational age, and neonatal respiratory distress syndrome. We have Dalfra et al. Who suggested that GV index, glycemic variability index, and average blood glucose level of the patients with the GDM are only slightly higher than the non-GDM group. But even that slight increase affects the growth of fetus. And we have HAPO study which shows risk of large for gestational age with every standard increase in the maternal blood glucose concentration. And these are the studies which review of continuous glucose monitoring and GDM, Paramashivam et al., Lane AF et al., Zhang et al. And though outcomes has not been increased in many conditions, but it has shown hypoglycemia are well diagnosed and lower gestational weight gain, better behavior have been found. Open for discussion. So, okay.
Thank you, doctor. So what doctor emphasizes is that you should not stop with a single blood test. We need a 24/7 round the clock control for a better outcome, both for the mother as well as the child. In case of true GDM, which is more prevalent, you can just ask the patient to come in turns. That is, one time you see the morning blood sugar before and after, once in the afternoon and once in the evening. But as we all know, we cannot afford for that CGMS or ambulatory in all patients. In this way, if it is a true GDM, you can go like that. In case of pre-GDM, what doctor said that where the blood sugars are going to be very high, there you ask the patient to get a meter, at least have a glucose meter, and he can do the 7-point blood sugar. That is for all 3 meals, morning, afternoon and night, and along with midnight blood sugar where she should not go for going for hypoglycemia. This will be simple for day-to-day practitioners, what I feel, where because it's very difficult for us to go for CGMS and ambulatory even, which is very cheap nowadays. But always what I advise, of course in continuous glucose, we calibrate every day, whereas in ambulatory, the new freestyle, please always compare it with the glucometer values, because it differs because of the dilution which occurs in pregnancy. Always compare the blood sugar with the meter, what you have, then you decide. Overall, what doctor says that it is very important to maintain the control round the clock. It will be very much bad both to the mother. If at all she has complications, it will be aggravated, and outcome will also be bad. Thank you, doctor.
Thank you. Take-home message is to use in high-risk patients who are having more episodes of hyperglycemia and hypoglycemia by SMBG.
Thank you very much, sir, for wonderful deliberation. We will move on to the next topic for this session.
Valid for only 14 days.
Sir?
14 days. Patch is valid for only 14 days.
14 days.
Yeah.
Yes, sir.
So there are 3 trimester.
Yes, sir.
How many times you
So
can?
we can do it anytime we want, sir.
No. Normally in your practice, how many times?
Sir, usually this type of variability are used mostly in the 3rd trimester, sir. Mostly in 3rd trimester where the excursions, blood variable excursions are more. So we usually use it for 3rd trimester, not for 1st trimester and 2nd trimester. Only in pre-gestational diabetes we are using that. In gestational diabetes only in the 3rd trimester we are using.
Of course, time in range for a normal person, it is, that is type 2 diabetes is 70%.
Yes, sir. But
here you need more than 10%.
Yes, sir. More than that. Almost 90% we have
no
to.
doubt. This gives also the HbA1c value.
Yes, sir.
But this HbA1c does not always correlate with your HbA1c done outside. Suppose you do it in some other machine. The HbA1c not always correlate with this HbA1c of this test. And we have to give training to the patient, because of all the 14 days, even 3 days, 6 days, 7 days, she can absorb the machine and put it in the computer. So patient needs some training. Suppose patient in the house, then you have to give basic training. Every time she has to come to the hospital. For that, what is called this is Liber Pro. There is a Libre meter is available. If you show the meter near to the patch, it will show the result.
Results, sir.
Yeah.
We need not to remove the device.
Yeah. So patient can have own for her own purchase, and even after the pregnancy can use it.
Sir.
Thank you, sir.
Thank you, sir.
Thank you, sir. The next speaker for today is Dr. M.K. Sudhakar, MD, General Medicine, Senior Consultant in General Medicine, Porur, Chennai, who will be speaking on diabetes and vaccines. Over to you, sir.
Thank you, everyone. Thank you for the organizing committee for giving me this opportunity. First and foremost, I am going to talk to you on not for the vaccines for preventing diabetes. I am just